am Dr. Ranadhi. I am practicing diabetes and medicine in North Kolkata. So today our topic of discussion is ARB in diabetes, renal safety. So angiotensin receptor blockers, that ARBs, are among the most widely used antihypertensive drugs. They help in reducing the cardiovascular and the cerebrovascular risk and renal complications, hence minimizing the morbidity and mortality risks in patients with hypertension. Hypertension is an important independent risk factor for renal diseases. If hypertension and chronic renal disease coexist, as in common in patients with diabetes mellitus, the risk of cardiovascular disease is heightened. The renin-angiotensin system, that is RAS, plays a pivotal role in the progression of renal disease as well as in hypertension and target organ damage. The use of agents that target the RAS confer renoprotection in addition to antihypertensive activities. There are extensive evidence of the renoprotective effect of angiotensin 2 receptor blockers and specifically Telmisartan. In addition to providing 24 hours blood pressure control, clinical studies in patients with diabetes show that Telmisartan improves renal endothelial function, prevents progression of microalbuminuria and macroalbuminuria, slows the decline in glomerular filtration rate and reduce proteinuria in overt nephropathy. These effects cannot be solely attributed to blood pressure control. In contrast to other members of the ARB class, the renoprotective effect of Telmisartan is not confined to the management of diabetic nephropathy. Slowing the progression of albuminuria has been demonstrated in the ongoing Telmisartan alone and in combination with ramipril global endpoint trial, that is on target, which include diabetic and non-diabetic patients at high risk of cardiovascular events. The RSSDI guideline 2022 recommendation on use of ARB and their combination in patients with diabetes and hypertension. Number one is ARB have maximal renoprotective effects when compared with other classes of drugs. The risk towards side effect is also lower with these agents compared to ACEi inhibitor that induce cough. Number two is combination of ARB with an ACEi inhibitor is not recommended as it is associated with an excess of adverse renal events. ARBR, number three is ARBR administered in combination with other agents such as calcium channel blockers or thiazide diuretics to reduce the risk of CVDs and renal disorder in the patient of diabetes mellitus. Both ARB and ACEi inhibitor effectively reduce the risk of end-stage renal disease. Number five is ARB and ACEi combination therapy with SGLT2 inhibitor should achieve better control of blood pressure and estimated glomerular filtration rate. Number six is that CCB, when added to ACEi inhibitor or ARB, is associated with renoprotective and cardioprotective outcome compared to thiazide diuretics. And the last point but not the least is the combining SGLT2 with ACEi plus ARB inhibitors reduce composite kidney outcome among type 2DM patients with CKD. So that's all for today. Thank you.